Jeff, in your presentation, I don't think you mentioned, so maybe take a moment. What there currently are some FDA-approved Alzheimer's treatments for Alzheimer's. Talk a little bit about those and what they do.
Yeah, no, that's a great question, and I didn't talk about what is currently available. So there are basically 4 drugs that are currently FDA approved for Alzheimer's disease. 3 of them belong to the same family. So Aricept, Razodine, and now I'm having my Rick Perry moment. Exelon, thank you. Which is that third agency?
That third agency, right?
So those are all members of the same family. They're so-called cholinesterase inhibitors. They're designed to boost the level of acetylcholine in the brain. Now, back in the old days being the 1980s and early 90s, there was this big thought that acetylcholine was a really crucial chemical for Alzheimer's disease, and maybe most of the symptoms are due to a deficit in that chemical. Research has gone beyond that now, and it's pretty clear that it's not all about acetylcholine. It turns out that boosting acetylcholine keeps people a little bit more alert, a little bit more engaged, and I think kind of indirectly helps their memory. It's pretty clear that it does not change what's ultimately going to happen in the disease. It doesn't slow the decline. It doesn't change whether or not you're going to go on to get end-stage dementia or not. So it's not a so-called disease-modifying therapy, which has really been the holy grail of research, is finding a disease-modifying therapy, something that really actually halts the disease process itself. Rather, Aricept and its brethren are symptomatic therapies. And we prescribe them, and for a lot of folks they do help, but they're not going to change the overall slope of decline. Namenda is that 4th drug that's a member of it's kind of a family unto itself. And it has an even weaker effect than the cholinesterase inhibitors. It's also a symptomatic therapy, but it doesn't intervene in the disease process. It's not a disease-modifying therapy. So that's currently the state of the art, are these 4 drugs that are symptomatic therapies that are often very helpful. I tell my patients, imagine that there's a patient with a brain tumor, and they have an awful headache from that brain tumor, and they take Tylenol. And Tylenol for them is a great medicine because it relieves their head pain. It makes their life more livable. It's not doing a darn thing for the brain tumor. And I think Aricept's kind of like that.
Yeah, great. Thanks very much. So this individual asks the question, wife has physically very, very healthy, ApoE4, has ApoE4, has mild Alzheimer's disease. What therapeutic treatments would you be suggesting to this individual at this time? Asking about a series of non-FDA approved, some of them nutraceuticals, some of them things that, anyway, what would you be talking to this family about?
So, and I encounter this pretty frequently in my clinic. This is a very common situation. And I always emphasize to families, I really shake my rattle on exercise. Exercise is the number one thing that this person can be doing to help reduce the rate of functional decline. There is no pill that's been invented that does that just yet. We're trying hard to develop treatments that do slow the rate of decline, but right now exercise is the only thing. I take patients off of more medicines than I put them on in my clinic. I think that side effects of medicines are a big deal, especially for people as they age. I don't necessarily discourage people from pursuing nutraceuticals and herbal medicines and other things that they're passionate about and that they're interested in, because I can't with a clean conscience say that they don't work, because in many cases I don't know whether they work or not. But those things shouldn't distract from the things that we know help, like exercise, a good social and mentally stimulating lifestyle. Those are the things that we know are helpful. So as long as those other supplements and other things that a patient might want to pursue isn't interfering with those core things, it's probably okay.
Mm-hmm. So there are a few questions here about, you talked a lot about biomarkers and how it's going to move the process and the research forward. And people always ask, well, we sat down with you in your lab the other day, the first question that came was, when we were gathering, was, when are we going to have a cure? And it's, the thing we'd all love to know, and I don't expect you to answer that question per se. But imagine then, you know the work better than any of us. What do you think modifying treatments are going to look like? What do you talk a little bit about that?
Sure. So, my hope. So I started to tell you sort of my hope for how that 63-year-old guy, how in the future, how he might be diagnosed with something. My hope in the future is that you come in, you have a clinic visit, you complain about some very subtle, mild problems, or maybe even you don't have any problems, but your mom and your dad have dementia, and you're just worried about it in yourself. And the doctors order this imaging test and these other biomarker tests, and come back to you and say, well, here's it looks like you've got a great likelihood of going on to get Alzheimer's disease one day. Here's the vaccine, or here's the medicine that you can start taking now, and this will help to prevent that disease from ever taking hold. That's the future that I hope for. Not quite there yet, but I think that's where the research is heading.